Hi, everyone. I'm Ishani Shah. I'm a second year transplant pharmacy resident at Temple, and today we'll be talking about immunosuppression post kidney transplant. Before I begin, I wanted to go over some trivia questions with you. So take a couple seconds to think about the answers and then feel free to type them in the chat box feature on Zoom. So the first question that I have for you is, when was the first kidney successfully transplanted? All right, so the correct answer here is B, 1954. So interestingly, kidney was actually one of the first organs that was ever transplanted, and it was a live donor kidney transplant, and the live donor was actually the identical twin of the recipient. The second question I have for you is, when did the first cornerstone immunosuppressive agent become available? So the correct answer here is C, 1983. So you will notice that the first transplant was performed in the 1950s, and there's about a 30-year difference between the time that transplant was performed and the time a really good immunosuppressive agent entered the market. And the particular drug that I'm talking about is cyclosporin, which is a calcineurin inhibitor. It was really a game changer when it came to patient survival and patient outcomes, and now it's one of the standards of care for all of our post-transplant patients. So this really brings us to our topic for today as to why immunosuppression is so important after transplant. So when you think about it, anytime a foreign object, including a foreign organ, is put into your body's natural reaction is to attack it via various immune responses. So the whole purpose of immunosuppression is to prevent that from happening. There are three main goals of therapy. So you want to reduce the incidence of graft rejection, you want to prolong graft survival, and you want to prolong patient survival. There are two main types of immunosuppression. So you have induction therapy, which is intense and very potent prophylactic therapy that is given at the time of transplant. It reduces the risk of hyperacute as well as acute rejection. And then once we do that, we want to make sure that that is maintained during the patient's life. So we give them maintenance immunosuppression. And the purpose of this is to prevent both acute as well as chronic rejection. So let's start by talking about induction immunosuppression. There are three main agents that we use at Temple. So we have anti-thymocyte globulin or thymoglobulin. So this is our first line agent, and we prefer or try to use this in most of our patients. The dose ranges from 4 to 6 mg per kg, and the dose really depends on patient-specific factors. We might use a lower dose in our patients that are at the lower risk of rejection compared to somebody that has a higher PRA, where we might have to use a higher dose. Then we have basiliximab or Simulect. So we only really use this agent if the patient has a contraindication to thymoglobulin. And lastly, we have alemtuzumab or Campaz. And this is a very potent agent which we reserve for our patients with the highest risk of rejection, so patients that are undergoing retransplantation or patients that have PRAs of over 90%. So all of these agents are great, and their potency is really determined by their T cell depleting effect. So alemtuzumab tends to be the most potent because its T cell depleting effect lasts from 9 to 12 months after the transplant. The thymoglobulin, your T cell depleting effect lasts for about 6 to 12 months after transplant. The information on this slide is really there for your reference. My major takeaway here is that with thymoglobulin, we see prolonged infusion rates. So your first infusion could be as long as 6 hours, followed by 4 hours for any subsequent doses. Another important thing to remember here is that with your thymoglobulin, you give the the total load of 4 to 6 mg per kg in smaller divided doses. So your patient might be discharged before they actually finish the entire load. So they might have to come to an outpatient infusion center to receive the remainder of that medication. Uh, and it's also important to remember that with thymo and with Campath, we see infusion-related reactions, so it's important to pre-medicate your patients. Now we'll move on to maintenance immunosuppression. So let's start by talking about this picture here. So you can see that the green cell up here is the antigen-presenting cell. So the purpose of this cell is to identify the foreign object and present it to your T cell. Once your APC presents the antigen to the T cell, three signals are fired. So you have signal 1, signal 2, and signal 3. And once they're fired, a cascade of events begin, which ultimately cause T cell activation. And when you talk about rejection, most rejection cases occur due to T cell activation. So as we go through the next few slides and we talk about specific drugs that we use for maintenance, you will see that the main mechanism of action is either to prevent T cell activation or to prevent T cell replication. So before we talk about the specific agents, I just wanted to give you a general idea of the drug classes that we commonly use in different organ systems. So let's start with liver transplant. So we usually use a 2-drug regimen, which consists of calcineurin inhibitors or CNIs with an antimetabolite or AM. And we will be discussing specifics of these drug classes pretty soon. We then have kidney transplant. So in this patient population, we use a combination of CNIs, antimetabolites, as well as corticosteroids. At Temple, our goal is to stop steroids by post-op day 7 if it's possible. We then have heart transplant. So in this case, we use CNIs, antimetabolites, and then corticosteroids. And our goal is to taper the steroids by 6 months. And lastly, for lung transplant, we use a combination of CNI, antimetabolite, and corticosteroid. And this is one of those organ systems where they'll have to be on a 3-drug regimen for the rest of their life. All right, so the first class that we're going to talk about are calcineurin inhibitors. So as I mentioned earlier, they act on signal 1 by preventing calcineurin phosphatase activity. So this ultimately prevents T cell activation. There are 2 agents in this class. You have tacrolimus and cyclosporin. The doses are there for your reference. It's important to note that we monitor them in clinical practice by checking routine trough levels. So the purpose of the level is so that we can make sure that we find a balance between efficacy and toxicity of the drug. So for example, the goal TAC level usually tends to run around 8 to 10 within that first year of transplant. If our level is too low, we are putting our patient at a higher risk of rejection. But if our level is too high, we're actually exposing them to a lot more toxic side effects without adding any additional benefit. So it's very important that your patient's level always run within the set goal. When we talk about side effects of this drug class, nephrotoxicity is a major concern. So you might be wondering that why would we use a drug that causes nephrotoxicity after kidney transplant? So it's important to note that the risk of nephrotoxicity is dose-related, and we can often mitigate that by reducing our doses or reducing our goal levels. And then we check the levels pretty routinely in practice, like I mentioned before. Out of the 2 drugs, tacrolimus and cyclosporin, cyclosporin came to the market first. However, there's studies that suggest that tacrolimus is more potent and has better outcomes. So as our first-line agent, we always try tacrolimus before we do cyclosporin. There is a slight difference when it comes to their side effect profile. So with cyclosporin, we see more hypertension, dyslipidemia, hirsutism, and then with tacrolimus, we see more diabetes, neurotoxicity. You'll see alopecia, as well as hematologic disturbances. Again, the side effect of alopecia is more exposure related as opposed to dose related. So if your patient does experience this particular side effect, the only real way to mitigate that is to switch them completely over to cyclosporin or another agent. Moving on to tacrolimus formulations. So there are three brand names that are available. So you have Prograf, which is the immediate release formulation. We have Astagraph, which is the extended release formulation. And then we have Envarsus, which is also an extended release formulation. So currently, there's a national drug shortage of the immediate release tacrolimus. So at Temple, we're actually switching all our patients from Prograf to Envarsus um, to sort of help with this drug shortage. So even before the drug shortage, there's actually a lot of hype around this particular drug in the recent years. So Envarsus is, like I said, it's the extended release formulation of tacrolimus, and it was approved in 2015. It is made with a special technology. So it's called the maltose technology, which reduces the particle size of the active ingredient. So by doing so, they've actually enhanced its bioavailability and improved its absorption in your GI tract. So ideally, you actually need lower doses of Envarsus compared to the immediate release version of tacrolimus. Another important thing is to compare the pharmacokinetic or PK profiles of Envarsus with Astagraph and Prograf. So as you can see from the graph here, Envarsus has a delayed peak. So what that really means is that certain side effects of tacrolimus, such as tremors, as well as neurotoxicity, are associated with how high the peak is. So if your patient is experiencing the side effects on the immediate release formulation, switching them over to Envarsus can actually help mitigate those. And there's actually a lot of literature that supports that, and we've also seen it in clinical practice in some of our patients. The major difference between the immediate release and extended release formulation is the dosing frequency. Their Prograf is dosed twice daily, so you'll be taking one pill in the morning and one pill at night, whereas Envarsus is dosed once daily. So it's important to remember this difference, especially right now, because it becomes an important education point for our patients. So while we're converting all of our patients from Prograf to Envarsus, it's important to tell them that they'll only be taking this drug once daily. A lot of the times, in spite of constant education, sometimes their patients might get confused and they end up doubling their dose, which is not ideal because they are putting themselves at a higher risk of toxicity, particularly nephrotoxicity, which we're trying to avoid in this patient population. Um, Another important consideration with this drug is its cost. So it's a brand name product. It's very new to the market. So you can imagine that it is very expensive. So the company Veloxis, which makes this drug, actually has several programs that can help reduce the cost of the drug. So we have a 30-day free trial, which we use on all of our patients. You can use this on 2 different capsule strengths. And then they also have a $0 copay program, which is for commercially insured patients. For Medicare patients, you could use prescription assistance programs. So you basically need to report their annual income, and then the company actually provides prescription assistance. So we use that on a lot of our patients as well. And in order to assess eligibility for both of the programs, there's a simple questionnaire that needs to be filled out on the website. And once you do so, the patient or the healthcare provider can do so. And if you're eligible, they send you the card immediately. So moving on to cyclosporin formulations. So you have Sandimmune, which was the first brand name that entered the market. This is a non-modified formulation. So this is associated with a lot of problems because it has very, very poor absorption and very poor bioavailability. And then in order to mitigate that, we now have the modified formulation. So you have 2 brand names. You have Neorel and Gengraph. And mostly in clinical practice today, you will only see modified formulations because they have consistent absorption, they're less dependent on food, and you can reach your peak concentrations pretty rapidly. Just an important thing to note here that these 3 brand names are not interchangeable. So that wraps up our drug class calcineurin inhibitors. We'll now move on to the next drug class, which is antimetabolites. So these drugs work by inhibiting DNA synthesis. So they essentially prevent T cell replication. And that's why we use both calcineurin inhibitors and antimetabolites in combination, right? So calcineurin inhibitors they prevent T cell activation, whereas antimetabolites prevent T cell replication. So you're getting two different mechanisms of action, which can prevent rejection. The two drugs in this class are mycophenolate and azathioprine. So in clinical practice, we don't routinely check levels. However, it is possible to do so if you wanted to. Because out of the two drugs, mycophenolate is the preferred agent because it's associated with better outcomes and fewer side effects. With azathioprine, we see a lot of bone marrow suppression, pancreatitis, as well as LFT elevations. Whereas with mycophenolate, our major concern just tends to be GI side effects. So we can mitigate that by starting the patient at a lower dose and then titrating them up slowly. And if the patient does experience side effects on the higher dose, we can just lower their dose. And another important side effect of this particular drug is teratogenicity. So mycophenolate is associated with a REMS program. So all females of childbearing age have to be on an acceptable contraceptive method prior to initiating therapy. So they can be on an IUD by itself, or they have to be on birth control along with a barrier method. And it's important to educate your patients on this because a lot of the times when the patient has end stage renal disease, there is dysregulation in their hormones, and as a result, their chances of conception are pretty low. However, after the transplant, there are studies that show that your hormones actually become pretty normal, and the chances of conception or chances of getting pregnant improve significantly. So it's important to educate your patients on that and the importance of contraception because they probably did not need it prior to transplant, but now they'll definitely have to be on appropriate contraception methods. Another important teaching point is that if your patient does want to get pregnant once their graft function is stable, they absolutely can. They just have to let their providers know because we'll have to switch them from mycophenolate to azathioprine. So they ideally have to be off of mycophenolate for 6 weeks prior to them being able to conceive. This slide is mostly here for your reference. There are two brand names for mycophenolate. So we have Suncept and Myfortic. So with Myfortic, the only real difference is that Myfortic is enteric coated, and we usually use it to reduce GI side effects. Moving on now to mTOR inhibitors. So these act on signal 3 of that pathway, and they prevent the activation of mTOR. So ultimately, they also prevent T cell activation. There are two drugs in this class. We have sirolimus, which is dosed once a day, and we have everolimus, which is dosed twice a day. The studies have shown that compared to CNIs, they have higher rates of rejection, and as a result, we don't use them first line in clinical practice. So they're also associated with a lot of side effects. A couple that I want to point out are delayed wound healing. So it's actually recommended not using this agent within the first 3 months of transplant because it can actually affect the surgical site. And it also causes proteinuria, which is a concern in our kidney transplant patients. So if the patient is going to be on this drug, we monitor for urine proteins very closely in our patients. So having said that, so this drug class is associated with higher rates of rejection as well it has significant side effects. Where do they really fit in clinical practice? So you can use them in addition to CNIs when you're experiencing intolerable side effects to CNIs. If the patient has a history of active or prior malignancy, we can use this to reduce the risk of nephrotoxicity. So if you identify a patient that is starting to experience nephrotoxicity with CNI, we could reduce their TAC goals and add an mTOR inhibitor. And then you can also use it in patients that have positive BK viral load or BK nephropathy. So there are some situations where you can completely substitute the CNI. So once you reduce the goals of TAC to reduce nephrotoxicity, if your patient is still experiencing that side effect, in that case, you might have to completely switch them out. Or if the patient has persistent BK viral load or BK nephropathy, in those cases too, you could choose to completely switch them out to an mTOR inhibitor. Our next drug class are corticosteroids. So I'm sure everyone knows about steroids and all the side effects that they come up with. The main thing that I wanted to focus here is that at Temple, we do use methylprednisolone induction along with whatever agent we use initially, and then our patients are put on a steroid taper. Our ideal goal is to be steroid free or use minimal doses of steroids. So we usually lower steroids within the first 7 days of transplant, and in most cases, we're able to stop it completely. If the patient does have autoimmune diseases, we do continue it for a lifelong period, but we use very low doses of 5 to 10 milligrams. And here I have an example of our steroid tapering protocol that we use at Temple. So having gone over all of these drug classes, we have now established that CNIs are the first line agents. We start all of our patients on that along with an antimetabolite. And then we also start our patients on steroids, but our ultimate goal is to wean them off of steroids by post-op day 7 or use very low doses of 5 or 10 milligrams. So an important question arises here is there an agent that completely avoids the risk of nephrotoxicity? Because we did discuss that CNIs are associated with significant nephrotoxicity. So the answer to that is yes, we do have a newer agent known as belatacept, and its main claim of fame is that it does not cause any nephrotoxicity. So this particular drug acts on signal 2, and it prevents co-stimulation. It is once monthly IV infusion, so it's also a good agent in our patients who are non-compliant. However, they will have to go to an outpatient setting to get that IV infusion every month. You can use it you have to use it in combination with mycophenolate and prednisone, and you ideally cannot be steroid free on this particular regimen. It does have increased rates of rejection compared to CNI-based regimens, and it also has a higher incidence of PTLD, or post-transplant lymphoproliferative disorder. So you do not want to use this in patients who are EBV antibody negative. So again, it's a great drug to try, but we don't routinely use this in all of our patients. So we start everybody on a CNI, and if they do experience side effects or if they do experience nephrotoxicity, which we're not able to mitigate by lowering their TAC goals, we could potentially switch them over to belatacept. So this is a newer agent that can also be considered. So that was an overview of all the agents that we use for maintenance immunosuppression. So I would like to pause here real quick for a knowledge check. So which of the following represents a typical regimen for a maintenance immunosuppression post-kidney transplant? So is it A, CNIs with prednisone, B, antimetabolites and mTOR inhibitors, C, CNIs with antimetabolites and prednisone, or D, CNIs by itself? Take a couple seconds to think about it. And the correct answer is C. So we do start all of our patients on CNIs and antimetabolites, and then we do start them on steroids, but then our goal will be to wean them off of that eventually. So for the purpose of today's presentation, I don't have time to go over infection prophylaxis, but it's just something to be aware of, that when we cause significant immunosuppression in our patient, we are increasing the risk of infection. So all of our patients will be started on appropriate infection prophylaxis. So we start valganciclovir for viral, particularly CMV prophylaxis, and it's usually used for 3 to 6 months post-transplant. We start Bactrim for PJP prophylaxis, and this is usually on for 1 year after transplant. And then we do nystatin swish and swallow, which is for fungal oral candida infections, which we do for up to 1 month post-transplant. So having gone over all of these new drugs that our patients will be started on, an important question arises: how many medications will my patient be on? right? So your patient will be on 2 to 3 new immunosuppressive agents. The patients will be on 3 infection prophylaxis agents. Your patient might be started on new agents after the surgery, right? So aspirin, statin, PPIs. Your patient might already have home medications that will be continued after the transplant. And then with time, your patients might develop complications post-transplant, which might be treated with new medications. So on average, most transplant patients take up to 20 pills a day, which is a lot. It causes a lot of pill burden, and it also increases the risk of non-compliance because patients just get tired of taking so many pills every day. So it's very important that we keep reinforcing and educating them about the importance of adherence. Because if your patients stop complying to their medications, it could result in acute and chronic rejection. It could cause impaired graft function. It could cause life-threatening infections. And the worst case scenario would be death. So this is where a pharmacist could come in and potentially help. So we do pre-transplant evaluations at Temple. So a transplant pharmacist will meet with the patient to assess medication adherence. So we go over their medication and allergies. We identify any barriers that they might have to obtaining those medications. We recommend how to better manage their medications, so using pill boxes, setting up reminders on their phone, using certain apps, maybe getting a caregiver involved, etc. We also identify potential drug-drug interactions with post-transplant medications. So ideally, if we can change those medications before the transplant, we try to do so. And we also provide education on post-transplant medications, so just so that they have an idea as to what to expect, how many medications they'll be taking, what side effects they need to be looking out for. Because a lot of studies have shown that constant education actually helps with compliance in our patient population. My major take-home points from today's presentation are that immunosuppression therapy has evolved over the years and it has significantly improved quality of life and survival in our kidney transplant patients. Our patients are going to be started on several new medications after transplant, both for immunosuppression as well as infection prophylaxis. So compliance is really, really important for a positive outcome. And lastly, education, both pre and post transplant, is very important because ultimately that's what's going to help get good patient outcomes, right? So constantly enforcing the use of pill box, setting alarms on their phones, getting help of a caregiver, and giving them very clear instructions in terms of doses, how to take the medication, how many times they'll be taking, etc. So with that, I conclude my presentation and I will be happy to take any questions that you have.